Good afternoon and good evening to everybody attending this session on single-use cystoscopes, why and when to use. I'm Bodo Knudsen from The Ohio State University in Columbus, Ohio. I'm going to be moderating this session today with my co-moderator and discussant, Kelly Healy from Columbia University. And then our two primary speakers are going to be Oliver Wiseman from Cambridge University Hospitals NHS Trust and Brian Eisner from Mass General Hospital. Next slide, please. This program has been accredited by the ACCME and the AUA. Credit designation is by the AUA. Next slide. Please note that all disclosure for today's panelists can be found at the World Congress of Endourology website. Next slide. Evaluations and CME info will be sent out on Tuesday by WCET. You do not need to contact anyone. Next slide. I want to thank Boston Scientific for the independent educational grant and also specifically AMView for this specific talk. Please note that today's presentations will include Q&A. If you have questions as we move through the presentations, please type them in the chat box and they'll be passed on to us. We'll be answering as many questions as we can throughout the session. I now have the privilege of introducing Mr. Oliver Wiseman, who's going to take over.
Thank you, Bodo. I'm actually not Oliver Wiseman, I'm Brian Eisner, but I'm Mr. Wiseman's partner on this talk. And I think I'd first like to say thank you for the Society for this event. Of course, thank you for the sponsors. We're incredibly grateful. And finally, I'll thank my partner in crime, Oliver Wiseman, who did a ton of work for this talk, as well as deserves credit for the videos presented. So we're looking forward to an exciting hour of interactive discussion and presenting some of our experience and views on single-use cystoscopy. Here are the disclosures for Mr. Wiseman and myself. And so we're going to basically go through an agenda that is outlined as such. We're going to talk specifically about the EMBU scope at first, talk about some use cases and present some videos, talk about costs of these devices or sort of estimated costs or thoughts on cost as compared to reusable, and finally discuss some other general concepts in the world of single-use endoscopy. As we're all aware, single-use ureteroscopy has been around for some time, as has some single-use cystoscopy, but we're going to focus on cysto here and draw some on our previous experiences. So first, I'm going to start by reviewing the EMBU A-scope for cysto. And here you see some pictures of the scope as well as some characteristics described. So again, this is a watertight endoscope with a 120 degree field of view. You see the depth of the field can be anywhere from 3 to 100 millimeters. And what we do note is that there is a really nice, clear, sharp digital image when we place the scope into the bladder. The scope, as you see on the tip here in the upper corner, has 2 LED lights for optimal lighting within the bladder. In terms of the shaft and scope design, it has a smooth surface for easy atraumatic insertion into the bladder. It is definitely stiff enough to navigate a, let's say, difficult prostate or to work on a urethral stricture. And we'll show some data or show some images of that in a few moments. Again, it has active bending as well. And so, now I'm going to show actually some other images of this endoscope. You see here, starting on the left-hand side of the screen, there's an insertion cord and a sort of umbilicus, as we may like to call it right here. You see the video cable. Give me 1 second here. Okay. Give me just 1 moment, please. I apologize for the technical difficulties. You see here the hand piece is ribbed for a comfortable grip. You see it's got a bending and deflecting lever, much like a reusable flexible cystoscope. And of course, it's got a working channel through which we can place instruments. So this is a video of Ollie's just to show very easy setup. Basically, you have your assistant plug the cord into the box. There you see the little cartoon on the screen, and you are ready to go. So setup tends to be quite seamless for this device, and I think that adds to its advantages in terms of portability, versatility, and maneuverability, many of which we will discuss later in the talk. This is just, again, a sort of bird's eye view of the setup in one of Mr. Wiseman's clinics, but you see really not a lot of space or a lot of footprint. We have the cystoscope here. We have the instruments or the fluid they're putting in there, and you saw the screen, and really that's about it. So this is a very small footprint, which does create some versatility. My own personal comments is that we've been able to use this in rooms that we couldn't use for reusable cystoscopy, and that's mainly because of the small footprint and sort of small size of the equipment. So we certainly in our clinic experience or our outpatient experience have performed cystoscopies in rooms that normally wouldn't be used for cystoscopy because this device allows us the space to do so. I'm going to turn it over to Ollie to talk a little bit about quality.
Yeah, thanks very much, Brian. Thanks for the introduction and for the opportunity to talk to you today. So if we think about the quality of these scopes, when we think about single-use versus reusable, quality is something which is always discussed. So there was a study which was done last year by Kimura, Scotland, looking at a single-use cystoscope and comparing that to the traditional Olympus flexible videoscope. The study revealed that the single-use flexible cystoscope demonstrated a similar field of vision. The visualization of the anatomy was fine. Image color and distortion also were very similar. The image resolution was deemed to be inferior to that of the reusable flexible cystoscope. Scope deflection of the single-use cystoscope was superior with an empty channel, but as you'd expect, there was a significant drop in deflection ability upon placement of the instrument through the channel. So overall, this single-use flexible cystoscope, which was a different brand, was said to be comparable to the traditional reusable cystoscopes, and it was able to be used in overall 96% of the cases. So next slide, please. This is more specifically looking at the A scope for cysto, which is what we're focusing on today from AMBU. And this was data is from a white paper which looked at the use of the scope by 380 urologists worldwide. And you can see in the bar chart on the right how the urologists rated the quality of the scope on a Likert scale from 1 to 5, with 5 being very good and 1 being poor. And you can see that for image quality, bending without a tool, bending with a tool, ability to navigate, overall performance, and the performance of the display unit separately, the A scope for cysto scored very highly indeed. And next slide, thanks. So one of the big advantages, I think, of the scope is that it's very versatile, it's very portable, and it can be used in a number of different locations. So these are just some of the areas where you may think about using it, and this is a UK-based slide, but this would apply pretty much anywhere in the world. I work in a big university teaching hospital, but also in some smaller clinics as well, where certainly the economics of having reusable scopes certainly don't add up. Also, while you may have your endoscopy unit, which is set up for high throughput cystoscopy, it's nice for us to be able to use cystoscopes in a number of different areas, such as in theatres, such as in outpatients, and such as in the accident and emergency department. And we'll look at that flexibility and versatility a little bit over the next few slides. Thanks. So it is highly portable. So Brian showed you the setup of the scope and the footprint, but the monitor is a little iPad type monitor, and despite that, the resolution on it is excellent. And all you really need to be able to have is that monitor and a single packed scope, and you can pretty much take it anywhere in the hospital. It can be taken to the wards, and certainly having one of these units in A&E is a very useful tool to have when you're managing emergency patients, as we'll see in just a moment. Next slide, thanks. And the next slide, please. Okay, so if we move on to just look at some cases and think about some scenarios where this person...
Ollie, for 2 seconds, did we want to pause and allow our moderators to ask us a few questions before we move on to our videos?
Yeah, let's do that. Great.
Have you gotten any feedback in your experience from staff on the ergonomics of setup? You've commented on your surgeon experience and ease and portability of advice, and also on just turnover of rooms, even in your cysto clinic.
Yeah, I mean, you know, it's certainly very, very easy for the staff to use. The really nice thing about it is that, you know, you don't have to pack everything back up, transport it back on a trolley up to endoscopy to be sterilized. You know, it's just a packet, you open the packet, you plug it in. So from the staff's point of view, they really find it a lot easier to manage. And then they haven't, if you're managing a list of cystoscopes, they haven't got to kind of keep on thinking, when's the next one coming? When's the next one coming? Are we going to have enough? If, for instance, in your unit, you have 3 or 4 cystoscopes, but you have, you know, 6 or 7 on your list, then you're always worried about whether you're going to have just-in-time delivery of a sterilized or a, you know, disinfected, reusable cystoscope. So it certainly takes that anxiety away as well.
You know, Kelly, I have a similar experience to Ollie. You know, the first thing I'll say is that whether the staff are experienced or not, the learning curve for the setup is quite small. I mean, if they know how to set up a blue towel for a sterile field, you see Ollie had a small Mayo stand there. We do the same. So the staff certainly quite like it. And then the other thing where our staff have been most pleased with this, of course, and we're going to talk about this in a minute too, is for the add-on cases. You know, so we have a fixed number of reusable cystoscopes in our clinic, right? And so if I see someone that has gross hematuria that I didn't anticipate before that office visit and wasn't booked for a cystoscopy that day, I can either bring them back in 2 weeks or quote unquote add on the cysto. And the ability to actually bring this equipment for one of our techs to bring this equipment just into a room that's normally an exam room, set it up and do it is has been quite beneficial for us. So we will touch upon that, I think, in a few additional slides. But I'll just say that yes, the staff has certainly been very pleased because the ease of use and setup is quite the learning curve is quite short for them.
I might have missed it, but any option to run it off a battery pack?
So you don't need to run it off a battery pack because the light source comes directly from your monitor. So there's no need to do that.
But instead of plugging the monitor in?
The monitor can be charged and you can take the monitor around with you.
Yeah. And how long does that charge last, you know?
Oh, I mean, it hasn't been an issue at all. I don't know exactly how long it lasts, but, you know, we haven't run out of charge. And if you need to, you take the plug and you plug it in by the patient's bed, right? So it's not an issue. Yeah. And so I think the battery pack and the light source is something that's worthwhile highlighting here, because before, if you wanted to go and do a cystoscopy in the emergency department, you know, you'd have to find all the bits, and you would have to find the light source, you'd have to find, you know, the various, you know, bits and pieces, plug it in, and that, particularly given the distances between where we keep all of our kit on the ward and the emergency department is, you know, could take quite a long time for our residents and our junior doctors to do. So this just simplifies everything. It's certainly much easier.
Yeah, I would agree with Ollie. You know, in our system, or at least at our hospitals, you know, our outpatient clinics are physically quite separate and have a separate equipment sort of workflow than inpatient or emergency. And as Ollie points out, you know, when we have to flex cysto someone in the emergency room to place a catheter, we have to go up to the operating room and wheel down a big tower, like the same kind of tower I would use for a perk. That's just sort of the way it works at our place. And when our residents and our house staff first saw this device, you know, their eyes, you know, went wide open, right? Because, you know, Ollie obviously showed a picture of himself carrying this stuff around, but we all know that we work in teams and groups, and in many, especially teaching hospitals, but even not, the house staff's running around cystoing patients to place catheters or helping us set those up. And again, it's just quite seamless as opposed to taking that equipment from the operating room and including a sterile cystoscope. So there are many use cases for this device, but I do appreciate doing the cysto in a place we don't typically do cysto much easier in our system than wheeling down a tower from the operating room.
Yeah, I mean, just one more point on that, Brian. That's definitely true. So we never used to wheel down a tower, but what that meant was that the surgeon who was doing the procedure would be eyeballing it, which isn't great from their point of view ergonomically, but also from a teaching or training point of view, it's not great because I couldn't see what the more junior doctor was up to. And so I think that's certainly improved things from a training and teaching point of view and safety point of view as well.
Fantastic. I have no other questions. Maybe we'll move on to some videos, Ollie.
All right. So if we move on, so we've just got a few different scenarios as to where you may want to use these scopes. I mean, traditionally in our hospital, all of our cystoscopy has been done in the endoscopy suite. If we've had a patient who's been on the ward, we would have had to take them there to have their stent removed, for instance, or if they come with hematuria and it's clearing and, for instance, they're not very mobile, you're not going to want to bring them back to the hospital, then getting their cystoscopy done on the ward has also been pretty difficult. So being able to do it on the ward has been good. Being able to do these in the outpatient department also and running a kind of one-stop service is very helpful, and that's certainly what we do, at least in our private practice at the moment. As Brian was mentioning PCNL, we will often during PCNL want to do a flexible nephroscopy at the same time. And so having a smaller footprint within your operating theatre with just a small monitor to allow you to see what's going on. And then also thinking about maybe not using a reusable scope through which you're going to maybe pass a laser fiber and a basket, making it more likely that you're going to damage your reusable scope when using it in conjunction with a PCNL. Also, I think lends itself very nicely to a single-use cystoscopy in conjunction with PCNL. But we've started talking a little bit about the emergency department, and clearly in the emergency department, I would say most commonly we would use it for assisting placement of a Foley catheter where there's a problem catheter that won't pass. And then we can just move on, Brian, thanks. So this is just a diagnostic cystoscopy, and it's just an opportunity really just to see the clarity of the vision. And you'll know, those of you who have used some of the single-use ureteroscopes, some of the versions of them, they only have a single light source on the tip, which can mean that you get a little bit of a penumbra or a shadow, either around the top of the screen or around the bottom of the screen. But you can see here with the two light sources, you really get a really nice picture, very clear, bright, and then also the autofocus, I think, works very well, and also the adjustment for brightness as you go towards the wall of the bladder, you'll see is also very good. This isn't actually the swiftest cystoscope that you'll ever see, but the importance also in cystoscopy, which Brian alluded to, is being able to do that J maneuver, so the retroflexion, to allow you to see what's going on back at the bladder neck. So you've got a 210 degree retroflexion one way, 120 the other way, and you can see that with the scope, you've got the maneuverability to do exactly what it is to allow you to view all parts of the bladder. I think we'll get to our retroflexion in just a moment. So you see here, very good clear view, good color representation, and then just going in to have a look and do that retroflexion to have a look back at your bladder neck. So I don't think that you could easily say that the image here with a single-use cystoscope is going to be inferior in quality to what we would usually see with a reusable cystoscope. We can maybe go on to the next one, Brian, thanks. Okay, so this is a situation that some of us, would face in the emergency department. We've tried to place a catheter, and the catheter just won't advance. And then, as I was saying previously, for us, that would mean then that we would need to go back to the ward, which is where our reusable cystoscope is kept. I measured it the other day. It's about 0.7 of a kilometre walk to the ward from the emergency department. So you're talking about a 1.5 kilometre round trip, plus finding all the bits that you need. And with our single-use cystoscope, you can see here, this is a patient who has got a urethral stricture. They presented in retention. So you've got a perfectly good view of that. And then with our single-use cystoscope, you can then just pass a wire through that stricture, and then we'd use some dilators, and subsequently we would pass a catheter over the wire, which is advanced into the bladder. So really allows you to, quickly deal with the patient, safely drain the bladder. I think that the days when you need to do a suprapubic puncture, they're not completely over, but it's so much less common than it used to be because we've got all of this technology, which really allows us to manage these patients, I think, much more safely. And the next slide, thanks. And then we mentioned in the operating theatre that we may need to use a flexible cystoscope, and I mentioned PCNL. But sometimes you have patients like this, where in fact you can't get a rigid cystoscope into the bladder because of the anatomy. It's not possible to abduct the legs, and in fact this patient had bilateral ureteric stones and a stone up in the left kidney. So you can see that you can use in the OR a flexible cystoscope to place your wire up to the kidney, and then over your wire you can then do whatever it is that you would like to do from an endourological point of view to manage those stones. And here it was the passage of a flexible ureteroscope up to the kidney. So you've really got that flexibility to use a very portable scope wherever it is that you need to. I think it's over to you then, Brian.
Yeah, thanks, Ollie. So this is a video, again, of Dr. Wiseman's of cystoscopy with stent removal. Again, this scope, as you could tell, has quite a nice digital image, which could be used for any purpose. In our practice, we have a fairly active bladder cancer surveillance program. And frankly, even with a armamentarium of reusable cystoscopes, we often have just not enough around. And so, again, if you wanted to say, well, we'll relegate this for stent removal, or, maybe something that's just going to be, a little quicker, a little more, sort of high throughput, and perhaps, save the reusable cystoscopes for bladder cancer surveillance. That's one way to do it. Although we also use these for cancer surveillance as well. But obviously you see the case for stent removal. You see a beautiful, clear picture here. Again, I don't really see a scenario where a reusable scope would be superior, certainly for this kind of thing. And you see the stent comes out seamlessly. And obviously, this can be performed in the outpatient setting as it is in our practice. And then, sorry, let me advance the slide for a second. This is just a still image, but the other things that people are doing in the office obviously are Botox injection. I don't personally do a ton of that, but we certainly do it in our practice. And keeping that procedure in the office obviously has its advantages for the patients and the surgeons. It's quite interesting if we think about cystoscopic cases we can keep in the office. Where perhaps you could do 3, 4, 5, 6 in an hour, whereas at least in many hospitals in our country you could do a 10 or 15 minute cysto case in the operating room, but the turnover time is longer than the operation. So keeping cystoscopy in the office and leveraging single-use cystoscopy to do that, I think, is another advantage of this kind of technology. And then finally, I want to talk about flexible nephroscopy. At the end of a PCNL, and Ollie sort of alluded to this before. I think especially It's interesting. I was part of a panel a few weeks ago where we were discussing flexible nephroscopy after miniaturized PCNL, and especially with some of the rigid metal miniaturized PCNL sheaths. I would imagine that, there are, especially for a tight fit with the reusable flexible cystoscope, there is the opportunity to damage those scopes. And so, I think for flexible nephroscopy after miniaturized PCNL, one could argue that mitigating the risk of damage to those scopes may be achieved by using a single-use scope through those metallic sheets. So, I do think there's a consideration, as Ali pointed out, for if we need flexible nephroscopy or cystoscopy during a PERC and either don't have the resources or for a flexible cystoscope, or it's cluttering up the room too much, or you're using a metal percutaneous sheet that may risk damage to a reusable scope, those may all be nice use cases for flexible nephroscopy using a single-use cystoscope. Ali, I think it's back to you.
Yeah, thanks, Brian. I mean, I think it's also just worthwhile saying that, those are the sorts of cases also where we're going to potentially be passing a laser fiber through the scope and or a basket to, remove bits of stone. And those are when our reusable scopes may be more likely to become damaged. So another good indication perhaps for a single-use scope. And also just to say, you talked about stent removal, and we have actually moved all of our stent removals out of our endoscopy suite. We now use a single-use scope to take all of our stents out. It's given us a lot more capacity in our endoscopy suite to manage hematuria patients, to manage cystoscopy follow-up patients. But what we've also shown and published on is that it's actually led to a reduction in delay of stent removal. You know how it is. We've got cancer diagnostics. They always take priority. Our stone patients who've got stents in, well, they can wait a few more days, right, because we've got to get this cancer. And particularly in the UK, we've got targets whereby we have to see a hematuria patient within, X number of days. So we showed that having control in our own department, and we took all of our stent removals to our lithotripsy suite. They're done by our specialist nurse with a single-use scope, and it significantly reduced the delays in stent removals for our patients. So a big plus for patients. This was part of a study which just looked at the use of the A scope for cysto to see what sort of environments was it used in, and I showed you earlier on the data from the 380 or so urologists or cases who'd undertaken its use. And you can see here that the majority is kind of what you'd expect, first time examination, maybe a diagnostic cystoscopy for hematuria or for low urinary tract symptoms, another 30% or so of follow-up examinations. And then there's a smattering of other things, of which stent removals are the next largest group, and a few Botox injections and other things. So it's got a wide clinical use, I would say. And then if we just hone in a little bit, Brian, on the next slide, which just shows those patients who had a procedure done during it, or some tools which were used during it. What were those tools? Well, you can see that it was, generally speaking, a stent grasper was the commonest one, biopsy forceps, Bugby electrode, laser, Botox needle. So compatible for all of the sorts of things that we would want to use a cystoscope for.
Thanks, Ali. So now we're going to get a little pause and see if our moderators or the audience have any particular questions about the last portion of the talk before we move on to costs and other characteristics of the scopes.
Yeah, quick question. So sometimes the Achilles heel with some of the digital scopes is when you do get into some bleeding that it can occasionally be challenging. How have you found it with this scope? Better, worse, the same as other digital scopes in terms of dealing with blood?
Yeah, sorry, Brian, go on.
No, go ahead.
I was going to say, I don't think, Bodo, I've noticed any real difference. I think it handles, pretty well in all environments. I don't think I've had any particularly challenging cases, where I would have thought, gosh, this is difficult. I think, for us, sometimes The stent removals can be, the hardest ones. There can be a fair bit of edema and bleeding, and particularly if you've got, big prostates on the way in. And I wouldn't say that I found any of those particularly challenging. So for me, I don't think it's been an issue so far.
Yeah, I was going to say actually the same exact thing Ollie said. Obviously there's these people that come in with gross hematuria, and you either got to let them clear or take them to the OR. But I think when I think about my office practice, it's the stent removals with the, and the patient on Plavix with the big prostate where you're often struggling. But I would agree with Ollie. I mean, I think the nice thing is the irrigation channel works well and it clears the field. And so I treat this like a regular scope photo. I have if I really can't see, I have my assistant give a little squeeze on the bag. But I'll say this, we certainly have taken out plenty of stents with people with hematuria, but I've never had to sort of convert and pull out a reusable scope if that is sort of any barometer. So I would agree with Ollie. I think they, sort of function very similar to the regular scopes, and that's how we treat them. And we haven't had any sort of negative comparisons or any reason to convert because of, let's say, failure due to visualization to date.
I've also noticed an experience, we've trialed and had several of the disposables here at my institution, that this offers a lot more versatility in sort of challenging scenarios, especially the large prostate, where this is equivalent to the reusable scopes and in my practice, superior to the other disposable cystoscopes for the large prostate. The flexion seems to be superior. So I think from a clinical challenge scenario, this is equivalent, if not superior, to what I've seen on the market. I did have one question. You mentioned shorter dwell times of stents. Have you noticed any impact on emergency room bounce backs or infections? There's been some data on less infections and less bounce backs in some of the other devices that have the built-in grasper, for instance. I would expect a similar outcome and benefit with this scope.
Yeah, so I think the ability to get scopes stents out in a timely manner will mean that. It's not something we actually measured in the study, and we certainly should have done. But I think you'd expect that. But certainly, if you look at from a patient quality of life point of view, getting your stent out sooner is certainly going to make a big difference to them. I think just the other point about bleeding to make is that one of the scenarios where it may be most challenging is in PCNL, where you've got some bleeding and you're doing a flexible nephroscopy. And I haven't seen any problems with illumination or the vision, I would say, during flexible nephroscopy at PCNL. And I think that we had a comment also from Ben Chu to say that his experience was similar regarding PCNL and the use of the a scope for cysto.
Yeah, Kelly, we also haven't really sort of looked at it in terms of the ER. I mean, but I would say this is right part of our workflow, in terms of stent removal and other cysto. But I would make one other philosophical point, which you sort of said about, difficult prostates, or, Ollie showed a patient with very bad scoliosis and a bunch of, musculoskeletal problems. And, philosophically, it's sort of like the single-use ureteroscope insofar as there are some people that say, well, for a case I know upfront is going to be difficult, I will take out a single-use scope because the risk of breakage is high, and I want to sort of mitigate that risk before breaking my reusable scope. And I would say much the same philosophy for a single-use cystoscope. When you have that, patient with a bunch of musculoskeletal deformities, or someone that's just going to be a really difficult cysto, or somebody with a massive prostate where you may have to, let's say, use a laser in the bladder, as Ollie pointed out, all the more so you can mitigate a reusable scope breakage by using a single-use scope. So philosophically, and I do not practice at an institution where we're fully converted to single-use. We have them as an option, but we use many reusable scopes. But philosophically, if I'm worried about a high risk of breakage for an office procedure or an OR procedure, I think, again, this fits in really nicely. I do want to see, Kelly made a comment about the illumination. Excellent. So I think if there's no further questions, we may kind of move on to cost. Oops. Okay. So, I think that one thing we have to remember, and first of all, I don't think surgeons are great at understanding cost, because I think there are so many variables that we don't ever address, don't ever think of. And, it's not just about buying one thing and reusing it 100 times versus buying 100 things, right? There's personnel, there's equipment, there's the environmental impact. There's a lot of sort of quote unquote costs that go into the decision whether to use anything reusable or single use, right? As not just cystoscopes, but let's say that certainly there are some obvious drivers of that, things like purchase of capital, things like repair and sterilization. Of course, the opportunity to do cases where you couldn't already, and I'll kind of get to that in a minute. And that may be because you can do them in a new location, which we've already talked about. It could be because your reusable scopes are broken and you still have the ability to sort of perform cases. But, I'd say as surgeons, we're probably not super great at understanding all these costs. I found in the journey of thinking about single-use endoscopy in general, whether it's ureteroscopy or cystoscopy, I learn new things every day. And I've certainly worked with our sort of purchasing folks and our value assessment committees to really understand this, so we can understand the best fit for this. Because I think on the whole, single-use endoscopes probably have a place in most practices. Some it's going to be a big part of that pie, some it's going to be smaller, but I think some of that is running your own finances and understanding those things. And no one's going to sort of do that for us. So if we think about our costs, at least the way we think about it in our outpatient clinic. So I'm specifically talking about our outpatient clinic because the hospital sort of runs its own cost center. But for us in our outpatient clinic, possible advantages of single-use cystoscopy may include, there are places that are going to replace everything. And if you think about, a full replacement of, let's call it your army of reusable scopes, certainly that avoids all the capital purchases other than the small screen, as well as the repair costs. I think that's an extreme place, and I don't know that I would start there. But, if you wanted to take at least this sort of extreme case, one could argue that, for a place that maybe is capital poor, but can generate revenue on procedures, that perhaps, the incorporation of the rising incorporation of single-use endoscopy may also mitigate some of the capital costs. And then for us, where I think this has actually come in very, very handy in our practice, is performing cystoscopy in locations where reusable scopes cannot be sterilized. So Ali sort of alluded to his endoscopy clinic versus the other places where they're doing this. One thing that happens for many places in the U.S. is that, believe it or not, certain healthcare settings are under different rule sets in terms of sterilization. So, if your office is attached to a hospital, you may fall under kind of the hospital's, rules for sterilization. Freestanding clinics tend to fall under other rules, but there also are scenarios where the rules are sort of too stringent or too financially insurmountable for us to implement them in our smaller clinics. And so for some of our smaller locations, we have fully or majority converted to these scopes simply to avoid not only the cost, but frankly, the hassle and the sort of throughput of re-sterilizing the reusable scopes. So I want to give a cost example. I want to be very clear. These are not the numbers from my institution. These are not the numbers from my office. I think the billing folks keep those fairly confidential, but these are reasonable estimates based on literature and a lot of sort of work I've done in this field or this area. So again, these are not my clinic costs if anyone's looking for them, but they are estimates that I think will help paint the picture. So here are some things that, perhaps before I thought about single-use endoscopy at all, I hadn't really ever thought about. But first of all, when we sterilize our scopes from our reusable scopes from the office, we actually either sterilize them ourselves in some locations, or we basically have to send them to the OR and we're charged to sterilize them. And that's about $70 to $80 per use. The other thing for our digital cystoscopes, and I do think that many of my partners, especially my partners who do any sort of oncologic surveillance, have a strong preference for the digital endoscopy. But, we're repairing and maintaining, scopes at $5,000 to $10,000 per year. And again, depending on your breakage, that may go up or down. The capital cost of a video tower, somewhere between $18,000 and $20,000. And in our practice for our reusable scopes, we have about one tower for every 3 to 4 cystoscopes. And then there's the cost of the scopes themselves. And then, of course, the last thing to know is that cost sort of ends up being renewable. So new capital purchase, will happen as the scopes, become smaller and more advanced. And, every sort of 5 to 10 years, even your top of the line digital scope becomes sort of a little bit outdated. So this is not an argument against reusable scopes, but just the reality, at least in our system, of using a reusable digital cystoscope. And so in a highly efficient practice, or so, let's say, we have a big 20-person group, we have a sterilization tech that we have on site running all the sterilization, and we're doing, some days 20, 30, 40, 50, in excess of 50 cystoscopies in our office in a day. In a highly efficient practice, the per use cost of a reusable cystoscope ends up somewhere between $100 and $150, just based on, again, the estimates I listed above. So now all of a sudden it's not a comparison of buying a single-use scope versus nothing, but rather the cost of use of a reusable digital cystoscope. And you see that, again, whatever the exact numbers, you see that all of a sudden the cost numbers become fairly comparable, let's say, without kind of nitpicking numbers here and there.
Brian, I'm just going to jump in there just for 1 second if you want to go back one slide.
Oh,
so we published at our center kind of a micro costing look at stent removal. So not just regular cysto, but cysto and stent removal. And we were $160. And keep in mind, that's with a reusable stent grasper. And the Olympus reusable stent grasper is no longer available. It's gone single use. And it's roughly $50. So that's actually going to push that cost up quite a bit. So something to keep in mind. But yeah, we were right at 160 with a reusable grasper.
Yeah, and no, I agree, Bodo. And obviously, again, this is not, cost is but one cog in this wheel of the decision making. But, when you already own a sort of fleet of reusable scopes, it becomes a little, at least for us in our practice, it became a little hard to wrap our head around, well, now we're going to lay out all this money for single-use scopes, so we already own these other scopes, and, if we already own them, why are we adding a marginal cost? But, again, if you look at the sort of, per use cost of the reusable cystoscope, again, it's for what it's worth comparable or close to buying a single-use scope. So appreciate that your data corroborates these estimates that I sort of got from the literature and other sorts of research. And of course for us, and I think, again, Oliver sort of alluded to this too, but, imagine if you can do an additional procedure, which means you can do an additional diagnostic cystoscopy, downstream, right? That's more sort of OR cases and more patients we can treat, And so if the addition of single-use cystoscopes to your, already reusable sort of fleet can also increase the total number of cystoscopies, you may be looking at finding more bladder tumors and helping more patients with bladder cancer, for example. The other thing as well is that, again, we have sort of run into situations where sometimes we do things in the operating room or because it's not that easy to just find time for them or space for them or cystoscopes for them in the office. And Botox did kind of occur that way for us a bit as we're kind of, everybody's fighting for the reusable cystoscopes, right? The people like me who remove stents, right? The bladder cancer folks, the neurogenic bladder folks that want to give Botox. So there were times we pushed some Botox to the OR. And again, by, just optimizing your fleet and armamentarium, keeping those procedures in the clinic, at least for us in the United States, is a much better choice financially for what I think is the same patient outcome. And not to mention the fact that you spare the patient the day in the OR with the general anesthetic. So those are some sort of thoughts on the cost in the US. And I'm going to turn it over to Ollie to talk about UK costs.
Great. So thanks, Brian. So we have done some micro-costing analyses in the UK. I say we, it's my colleague actually, Weston Mamalji in Hereford. And he looked at the cost of the Ambu A scope for cysto compared to a traditional reusable scope. In 20 patients, they looked at the costings retrospectively. They considered all the sorts of costs that Brian has already talked about. And I can show you in the next slide exactly what that showed. So you can see that the costs for the single-use Ambu scope were £135. The cost for the traditional flexible cystoscope was £166. So you're talking about a 31 pound saving. That's $42, 36 euros per scope. And if you think about the volume of scopes that you would do in any one clinic or any one hospital in a year, you can imagine that's going to potentially translate through to a lot of savings. As Brian said, there are lots of different things to think about. We talked a little bit about the flexibility. We're talking about the costs now. I think there are two other important issues which we're going to come on to, which are the infection risks and also the environmental aspects, but we'll come on to those in a second. These are how the costs stacked up, basically. So you can see the capital cost is in the red here. You've got the repair cost for the reusable scopes in blue. You've got the reprocessing cost for the reusable scopes in the blue, which I think is probably similar to what you were talking about, there or thereabouts in the USA. And then you've got the procedure cost as well. And you can see that obviously the capital cost, the cost of buying the single unit comes out a fair bit more for the single-use scopes. But because you haven't got that reprocessing cost, the overall cost for the ambu scope was found to be lower. Let's move on then, if that's okay. So the other thing to say is that, as technology improves, as you can see from all of these different technologies that have been introduced, as they are introduced, the price starts high and then the price comes lower over time. And also with that, you tend to get better technology as well. So, if the economics don't quite add up in your unit at the moment, or, for a part of your practice or for all of your practice, then as costs change and as the technology improves, then in the future you may well find that they do. So it's not a, we're all in now or we're all out now. Maybe part of your practice will be in now, and then as costs come down or things improve, you'll move more of your practice over to single-use scopes in the future. So we've already talked about some of the potential advantages, and I think just looking at the time, we probably just need to just move through these fairly quickly, Brian, if that's okay. The single use, because we have a brand new scope each time, it's convenient, it's safe, and you're not worried if your scope is damaged. I mean, clearly this is a video here using a single use ureteroscope. And when you send these off for repair, they have multiple problems which need repairing, which tells us really that we're using a suboptimal reusable scope in each patient. And the commonest problem is scoring of the working channel through these very delicate instruments. But in fact, it's exactly the same when cystoscopes, flexible cystoscopes go for repair. It's that working channel tends to get damaged, usually by passing instruments down it. Next one, thanks. And so you can see here, as well as the instruments going down, you have repetitive movements backwards and forwards. So you may have some laxity on your deflection lever. And then also you are subjecting these scopes to decontamination and disinfection. So brushes are going down the working channel to clean them. You're then disinfecting them. So there are, issues with deterioration of performance of reusable scopes over time. And we'll move on to your next bit, I think, probably, Brian, if that's okay. Yeah.
Yeah. So I'll be the first person to admit that when the single-use ureteroscopes came out and people talked about infection, I was dubious. I was a little dubious that we had problems sterilizing reusable scopes, but it's a fascinating body of literature that's been developed. I think many people on this meeting are probably well aware of this. I think the first thing to know is that there's a huge variability in disinfection for reusable scopes. Again, this is, I think, some data from UK, but you can see that, first of all, there's no standard one way to do this. There's a lot of variability, which may also lead to variability in the outcomes of sterilization. You look here, governing bodies, public health bodies are now listing inadequate cleaning of reusable instruments as big time health risks. These are high priorities for hospitals and concerns. These concerns didn't exist when I was a resident, right? Nobody thought about these things, but there's an emerging body of data that we're not as good as we think we are at cleaning reusable scopes. You've probably seen a lot of this stuff again in the news and the lay press. And I'm going to kind of go about talking about this a little bit in a moment. This makes sense, right? If you look at, how someone might clean a cystoscope or a bronchoscope or a ureteroscope, there's so many small, tiny moving parts, right angles, blind lumens. It's quite difficult to clean them in certain situations, and they may be heavily contaminated with pathogens. Corey Ofsted is an expert in public health and an expert in scope reprocessing in the United States, and she's done a fair body of work. They started with endoscopes in the GI tract and, noted that there were many endoscopes that after processing sterilely and according to guidelines still showed evidence of microbes or bacteria on these endoscopes. This was a study where they looked at gastroscopes and colonoscopes, and they watched people follow reprocessing guidelines, and still showed that there was persistent bacteria and other sorts of biological products on GI scopes after proper sterilization. Again, another study from a different group, same idea, right? If you look very closely, especially in scopes that have been previously used in patients with infection, again, this is from the GI world, you see that some of them still harbor infection even after appropriate sterilization. Is this real in urology? Well, we certainly treat patients with multi-drug resistant infections. We certainly treat patients with bloodborne diseases like HIV and hepatitis C. And then, of course, as we point out in the lower right, we also treat immunocompromised patients. And so the question is, do we want to be reusing the reusable flexible cystoscope from the HIV patient or the hepatitis C patient in a patient an hour later after sterilization that has transplant or immunocompromised? And I think these are very provocative questions. I think there's going to be a growing area of study, but I am fascinated by what we're learning in this field. So just some examples in urology I wanted to point out. This is from the flexible ureteroscopy world, but I don't think it's a big leap. You see, again, a study of ertapenem-resistant Enterobacter and another study of multi-drug-resistant Pseudomonas breaking out on urology units for patients who've had ureteroscopy with multi-drug-resistant bugs. So, again, not quite the same as flexible cystoscopy, but I don't think a big leap considering that it's in the same tract. This is an unbelievable study by Corey Ofsted's group where a hospital, two large academic medical centers let their people in to investigate. I think that was very brave of those centers, but look what they found. They looked at ureteroscopes, again, flexible ureteroscopes, but same concept, it's in the same tract. And what they saw was even after sterilization, many of them had microbial growth, hemoglobin, protein, ATP, evidence of patient's blood, evidence of bacteria. And so again, this is ureteroscope sterilization, but I don't think it's a big leap to say that we should probably investigate this and learn what the effects are in cystoscopy. I'm going to turn it back over to Ali to talk about the environment.
Should we have a quick pause there before we move on to that, just to talk about infection? I'm just thinking about time. Are there any burning questions on infection, or should I move on to talk about environment? Okay.
Yeah, let's move on to the environment.
Yeah. So I think that, when we think about single-use scopes, this is often the biggest question that comes up. We're using a scope, and then right after we use it, even though it's perfectly functioning, it goes right in the bin. And we feel pretty terrible doing that, even with a single-use ureteroscope. But if you've got a list of 12 cystoscopes in a row, that's quite a lot of environmental impact that you're going to, be making. And so companies that make single-use equipment really need to address these environmental concerns. And I think it is quite high on their radar as well. Thanks. So just as a background, the NHS is said to account for over 5% of CO2 emissions in the UK. And the endoscopy department in the hospital environment is a third highest emitting department. So it's definitely a significant issue. But if you look at the environmental costs, there's some data behind it, and you look at the environmental impact of reusable and single-use ureteroscopes when comparing LithoView with the URVF, the total carbon footprint is actually pretty similar between the two. So it's not like the single-use scope has got a worse carbon footprint than the reusable scope. A similar study which looked at bronchoscopes and looked at the environmental impact of them found that in fact the reusable flexible bronchoscope had a worse environmental impact because of the detergents and the personal protective equipment that was used. And although that came back to being equivalent if the same set of PPE was used to clean 2 or more reusable scopes, clearly it's not just a fact that single-use scopes are worse than reusable scopes. You've got to consider everything that happens in that journey of a reusable scope around the hospital, cleaning, and the environmental impact of that. So companies can do some things to try and address the environmental concerns. They can recycle, they can carbon offset, or some would say, well, we're plastic neutral. The recycling is a really difficult one. And in fact, legislation-wise, and in the UK at least, the legislation does not currently allow for single-use equipment to be recycled and then used again in patients. It has to go to landfill. So before companies are able to think about a recycling program where they can maybe collect their scopes up, dismantle them, reuse some of the parts, we have to think about whether or not we can actually change the legislation to allow that to happen. Next slide, thanks. And when we're comparing single-use with reusable, we have to really make sure that it's a fair comparison. What is the impact of a single-use scope versus the impact of reusable? And then actually, if we're thinking about recycling, is the environmental footprint of recycling actually going to be any better than just taking the scope and sending it to landfill? So those are the sorts of issues that we have to consider and the companies have to consider when we're thinking about reusable scopes.
So, Ollie added this cartoon, this picture, which I love to this talk, where, IBM chairman in 1943 said, I think there's a world market for maybe 5 computers. This is a new technology. And again, for me, it's always about trying it and seeing where it fits in your practice and seeing where we can find patient advantages for new technology in general, not to say we need to do, a universal adaptation, but where does this fit patients? So, are urologists ready for this? Well, this is some survey data which shows you can see in many countries, upwards of 40% of urologists have an interest in attempting to convert to single-use cystoscopy for many of the reasons we've already stated in this talk. What you see here, which is interesting, is urologists are sort of admitting they know some of the story. They don't know other aspects of the story. Again, this is about, as surgeons, we don't always know the whole finance story or the whole sterilization story. But, hopefully Ollie and I have at least provided some provocative sort of comments as to why one may want to consider single-use endoscopy in their practice. And again, with across the across the world, 40% plus surgeons at least interested in this, I do think that this technology is here to stay. And again, finding the best fit is what we're looking for. So I think we've gone over a lot of these already, the pros and cons. Again, the ready availability, as well as the sort of portability and versatility of the single-use scope certainly is a big advantage. We also have to think about expense and environmental concerns. And I think we're all very well versed in the pros and cons of reusable scopes. But again, where does this technology fit in our armamentarium? I think it's going to be different in each country, in each hospital, in each clinic, in each environment. But again, I do think this technology is here to stay. And so again, if I was going to hammer home, several points, here they are. We reviewed this in spades in this talk, but there definitely are some advantages that we just cannot achieve with reusable scopes when we add on a single-use option. Again, I want to thank the society, the sponsors, the moderators, and my partner here, Dr. Oliver Wiseman. I started and ended this talk, but let's be very clear that Ollie provided a tour de force of these videos and a lot of the content here. So thanks, Ollie. Thanks to society. Thanks, moderators. And we've got about 1:30 left for any last-minute burning questions.
I think its application, the OR suite, remains to be revealed, but increasing opportunities to use it again in perks and the cost benefit of repairs will become even more apparent. And I'm excited about integrating it in this way. So.
Yeah, I think you guys did a tremendous job giving a great overview of this product. And, it really seems we're kind of on this precipice of really moving towards single use in a lot more products, and, endoscopy, it's really growing. So it's interesting, when you look at the cost data, that it's probably gonna make sense. So really kind of disruptive to the industry. So it's kind of exciting when things like that happen. I think the environmental impact part still, I think there's still questions. I would love to see a real expert in environmental studies speak on this, because I think you got to look at the production of the scopes too, and the shipping and all these other things, that go into it. So I'd love to hear like an independent third-party person who really understands the impact and where we're at. But fantastic job, everyone. So really want to thank you for putting all that hard work in.